He said casual, so. You have no idea how much angst I have about it. So, this is not a huge, like, I'm very, like, almost uncomfortable, but I'm like, I'm gonna do it.
Decided she may come to our talent show because I did text or message her, so I mean she didn't reply, but you know, of course that's what she doesn't want. She was last weekend. I heard now she's in Brazil this week, but who knows? Maybe she made the. Okay.
Like there is something.
Right, you're right.
Everything should be over there.
Going on.
Oh, boy. All right.
Dr. Aravali.
You can see it fine. I was a little anxious.
Dr. Blue.
Oh, sorry. How are you? Good.
Oh,
Look, we're gonna test my vision. Some of my prints are pretty small. Let's see if I can.
Yeah, exactly.
At least it's not a long.
Let's go.
Yeah, oh, there's jury down there. Hi, everybody. You guys have jury?
Yeah. I think we're just.
That's the other side. Those are the, we're on.
Oh, I see. We're gonna sit up. No. Here it comes.
Yeah, we still have a couple more. Yeah.
Maybe you should get up and down. Chip, you just get back down to sit.
I love that you just like nothing together. Like.
Actually,
Not down, I'm like, boy, I think that is.
I think I have experience, kind of.
Let me text her.
Thank you.
Yeah, one more, I guess one more. Should we start?
When I get back. And then you go ahead and. For session.
Yeah. Exactly. See the vote.
Hello. Yeah.
All right, court's now in order. The Supreme Court for the American Hernia Society has a busy docket this afternoon. The jury has been impaneled and instructed to only consider the evidence presented here and to remain impartial until the conclusion of the proceedings. With that said, we'll now begin with our first case presentation.
Thank you, Your Honor. Okay, so I had the easy part in this meeting because I just have to present the clinical case.
So thank you so much for the opportunity of being here and present this case. So this is the case of a 62 years old woman who came with the full metabolic disease package. She has type 2 diabetes, which by the way is with a very good metabolic control, hypertension and dyslipidemia. In the surgical history in the past, just a remarkable only umbilical repair in 2010. We don't know about the mesh they used, and also we have no idea about the size. And at that point, her BMI was 28. 28. And 6 years later, she had a small recurrence, and it was fully asymptomatic, no symptoms at all. So she went to the primary care physician, and they decided not to operate. And she did very fine until 2020 when the pandemics came to our world. And she lost her mother because of the pandemic, and she started eating, and she gained a lot of weight. And her BMI at that point was 38, so it was something like 30 kilograms gain at that moment. And as soon as she was getting more weight, the hernia increased in size, and she came to me with this thing. So I thought that an alien was coming out from the abdominal wall, but no, it was her hernia. But the most complex thing in this case is that 2 months before coming to my clinic, he's starting to drain feces through the abdominal wall. So the most remarkable things about her CT scan is that the hernia, the recurrence was 9 centimeters width, and she had a very big loss of domain. So in summary, the case is easy. 62 years old woman, BMI of 38, well-controlled type 2 diabetes. She has a M3, M4, W2, R1, 9 centimeters defect with a Carbon-Loss rule near to 2. Loss of domain with an ACA index near to 0.4, and colocutaneous fistula and probably chronic mesh infection. So let this guy fight a little bit.
Thank you, counselor. Your facts have been admitted into evidence, and the court will now hear argument.
Okay.
Ladies and gentlemen of the jury, I have been tasked with convincing you not to use a piece of mesh in this very challenging hernia. If I could have the slides, please, that would be helpful. I have very important disclosures. I work with many industry and funded mesh companies, and despite the fact that I get money from these companies, I'm going to tell you we should not use mesh in this difficult case. Patients and surgeons can choose to do something conservative and safe. Fix the hernia without mesh, avoid mesh in its entirety, or you can be cavalier and go for it. Single stage operation, take down the fistula, remove the mesh, do component separations, and drop in a myriad of different types of meshes that you hear about today. And what ultimately is the most important thing? You will hear that recurrence is so important, but I would argue what matters most is what matters to the patient. It doesn't matter what the surgeon thinks. It doesn't matter what the surgeon's recurrence rate is. What matters is what the patient thinks. And I have yet to find a patient who has had a prior mesh infection that says, doctor, I would rather have another mesh infection than a hernia recurrence. In fact, back in 2008, Martin Kurzer clearly said a good result is not simply a hernia that does not recur. So we need to keep that perspective in mind. We have all taken the Hippocratic oath to do no harm. That doesn't mean do rare harm. That means no harm. And in fact, there's something referred to as the rare event fallacy, which is a cognitive bias for individuals to underestimate the significance of a major event. In fact, this has been popularized as the black swan event, where we rationalize these catastrophic injuries that are obvious in hindsight. If we drop a piece of mesh in this situation, it's likely to get infected. And when we have to remove it, we'll think, maybe I shouldn't have used that mesh to begin with. Is mesh FDA approved for contaminated hernia repair? And the answer is unequivocally no. In fact, there are warnings on all package inserts for all mesh saying, if used in a contaminated setting, there's a high likelihood of failure. Why is it over the 50 or 60 years that we've had polypropylene mesh, there's not been a single mesh manufacturer that has done the investigational device exemption study to prove efficacy and safety? And the bottom line is it's expensive and they know the outcome. It's doomed to failure. Can surgeons use it off label? And the answer is Absolutely, yes. But according to the FDA, if you use a material off-label, the manufacturers can't talk about it. When was the last time you did something you weren't allowed to talk about that was actually ethical? I would argue that that's the case in this situation as well. Now, off-label mesh is unquestionably a risky practice. We know that contaminated hernias have higher likelihood of infections and long-term complications. That's because of the biofilm. The most common organisms that impact these patients, and in particular this patient, are E. coli, staph, strep. They all form a biofilm that impregnates the mesh and makes it impenetrable to antibiotics and makes it very unlikely to salvage. This is not something new. Back in 1967, Grinnan and Schmidt demonstrated that if you put polypropylene mesh in synthetic hernias, it has a high likelihood of failure. And in fact, in some of their retrospective series, 90% of those hernias needed to be removed. This, in fact, is a case that I performed recently in which I removed a mesh that had been placed 10 years previously. So many of these problems don't happen over weeks and months, they happen years following. Don't be fooled by the literature that says polypropylene mesh is safe and efficacious in contaminated hernias. If you look at this study that came out of Greenville, South Carolina, where they looked at no mesh, synthetic mesh, absorbable mesh, and biologic mesh with minimal follow-up of less than 2 years, they demonstrate that recurrence is less if they use a synthetic mesh. But the dirty little secret is that 2.5% of those synthetic meshes ultimately had to be explanted. If you didn't put a mesh in, you don't have to remove it. In fact, if you look at the long-term incidence of meshes and complications, it takes decades before you realize all the meshes have ultimately removed. So follow those patients for a long period of time. Kamal Latani has looked at 100,000 meshes in the VA system, and it's demonstrated that 1.5 of them of all comers need to be removed. But there's a 2.7-fold higher likelihood of mesh removal if it's placed at the time of a contaminated setting. And if they develop a deep surgical site infection, 1/3 of those meshes ultimately need to be removed. NSQIP data from 2021 looks at the incidence of complications associated with mesh in a contaminated setting with a bowel resection versus hernia repair alone, and demonstrates increased overall morbidity, surgical site infection rate, sepsis, reoperations, and readmissions. So significant increased morbidity associated with all of those events. In fact, the odds ratio ranges from 30 to 50% for each of these in an adjusted multivariate analysis. Another study published in JAMA Network looking at nearly 200 hernia repairs with or without mesh, again, demonstrate increased risk of complications if you use mesh. But what's fascinating is that many of these complications don't happen right away. They happen years after initial implantation, and they drive more reoperations and complications without actually increasing the risk of infection. Who in the room would concede that a bile duct injury is no big deal and we should allow it? Well, in fact, the Ohio State University has published that the fact that morbidity of a wound infection and a mesh infection is the same as a bile duct injury. We cannot allow that to occur. So in fact, we need to not use mesh in these contaminated fields. So I would argue that mesh is not FDA approved in contaminated fields. Off-label use is not appropriate. We should avoid the rare event fallacy. We should stick to the science because bacteria forms biofilm. There's no IDE studies. There's an increased risk of infection, and mesh infection is as catastrophic as a bile duct injury. So remember, our oath as a physician is do no harm. So yikes, just don't do it.
Thank you, Counselor. We will now hear oppositional argument.
Well, that was an empowered talk from Dr. Roth, but like I'd say, let's stick to the facts. And we're going to be talking about using mesh in an infected field. These are my disclosures. So what do we think we know? I think we all are worried that mesh is bad in contaminated fields. That's what we've been taught for generations. That's probably the bias we're coming into this debate. And how am I going to win this debate? Well, I'm going to tell you what we actually know based on the literature, which is that mesh does not increase the wound morbidity in a contaminated field. Why do we care? Why do we need it in this patient? You all saw those pictures. I think undoubtedly, if you try to do a primary repair on that 9-centimeter hernia with loss of domain, that hernia is almost 100% coming back. So we're trying to give this patient a durable, realistic hernia repair in the patient that we have in front of us. We're trying to minimize the need for another surgery, which you are guaranteeing that patient if you are not reinforcing this complex hernia repair without any type of mesh. And we're trying to improve their quality of life. Yes, will there potentially be mesh explants in the future? Well, what if you wait months or years to do that interval hernia repair? What's their quality of life going to be like when they have that recurrence and they're living with it for months or years before they can get back to get their definitive repair? So we're going to argue that a single stage repair is safe and is more effective and is actually going to improve the quality of life of this patient overall. So this came out 2 years ago. It's a comprehensive systematic literature review of the safety of outcomes of hernia repair using synthetic mesh in contaminated settings. This is the highest quality of literature that we have. And overall, their conclusions say most studies endorse the use of synthetic mesh even in contaminated fields. They have lower recurrence rate and similar wound morbidity. This is just a snapshot of one of several pages of over 20 articles that they reviewed. And the top article is one of the largest articles that actually does not agree with my conclusions about endorsing mesh. And so let's dive into the Choi article from 2012 that many of us use of the reason not to put in mesh. There's over 30,000 patients that had mesh and 30,000 patients that did not have mesh, by far the biggest study in this systematic lit review. The results said there was increase of post-op recurrences, obviously from clean contaminated and contaminated compared to clean cases. And when you look at this data of where they got these odds ratios of a 5 times odds ratio of 1+ post-op recurrence for class 3 contaminated wounds compared to clean, what their results didn't do is talk about the no mesh group. And if you look at this, the odds ratio of a 1 or more post-op complication in the no mesh group is actually higher than the mesh group. And when you look at their p-values, there's no difference in complications in the contaminated fields based on mesh versus no mesh. And so while their conclusion said, don't put mesh in any of these patients, I think we need to look at their own data a little closer, because those patients that had contaminated fields did not have any worse outcomes in terms of post-op complications compared to the patients that did have mesh placed. Let's look at another article that Dr. Roth also mentioned, this Warren article from 2020. Again, relatively large series, over 500 patients with contaminated cases. And the lowest rate of surgical site infection was actually in patients with the permanent mesh group. When you look, here's their data, 14% overall had an SSI in the permanent mesh group compared to the no mesh with 17%. And more closely, let's look at recurrence rate, about 10% in the permanent mesh group, but almost 30% in the no mesh group. So again, you are subjecting this patient to 3 times the risk at least of a recurrence. And I think in our specific case, it would probably be much higher than that. So I totally agree with the conclusions of this systematic lit review that mesh really doesn't have any increase in wound morbidity, and it certainly lowers the risk of hernia recurrence. So what about in actual colon surgery, which we're talking about, we think this patient has a concomitant colocutaneous fistula. Well, there's even less data about that, but there's definitely several case series that have pretty strong conclusions. This one saying there is no reason to believe that abdominal wall prosthesis must be avoided in contaminated operations when adequate surgical technique is used. That technique includes a bowel prep, sterile technique throughout the surgery, and limiting contamination as much as possible. This article goes even further and says it is unjustifiable to avoid the use of mesh in a potentially contaminated field when appropriate surgical technique is used. Again, if you use good technique and minimize contamination, you can safely put in mesh in these patients. There was one article I found that did disagree and said that mesh carried a higher risk of infection and reoperation compared to no mesh placement in contaminated and dirty infected fields during bowel resections. However, they admitted that the vast majority of the polypropylene patients were actually getting heavyweight polypropylene in an underlay fashion. And there's lots of data that shows that probably using an extraperitoneal placement while you're doing these cases is the safest option to reduce wound morbidity overall. So I would argue that most of us today would probably not use a heavyweight polypropylene in this situation, and we'd probably choose a different plane to put our mesh. So I don't think this study really applies to our patient in front of us. So what do we actually know? Patients with contaminated fields have worse outcomes. There's no doubt about that. But the mesh itself doesn't actually increase the wound morbidity, and that is backed by 20+ studies now in a systematic literature review. Overall, mesh placement offers the best option for this patient for durable hernia repair with associated quality of life improvement while minimizing the need for another surgery down the line, which you are guaranteeing without putting in mesh. Thanks so much.
Thank you, Counselor. Jurors, you're now tasked with considering the arguments that have been presented to you. Please select a jury foreperson to deliver the verdict once you've arrived at your conclusion. Thank you. Order in the court. The jury has reached a verdict.
Yes, the jury has reached the verdict. We had a lot of discussion and we all agree that the wisest approach in this situation, considering the fact that the patient is also diabetic, obese, and there are other factors that can be optimized at the second time. We all think that a staged approach in this case, so damage control at the first operation and put ourselves in the best possible condition if the hernia reoccurs, will be the safest option in this case. We are not burning bridges, doing more advanced component separation or advanced techniques to reconstruct the abdomen in the first case. And eventually, at the second stage, we will have all chances available for a better repair.
It is so ordered. Thank you, jurors. We appreciate your deliberation. We'll now move to the second case before the Supreme Court of the Order in the court. We'll now move to the second case in front of the Supreme Court of the American Hernia Society.
Good afternoon, everyone. I'm going to present a case because we're going to be doing a diastasis, and it's not as exciting maybe with the CT and everything, but I chose this case because it's something I struggle with personally and very representative of many of the things that I think a lot of us see in clinic. So this is a case of a 29-year-old woman who comes to your office who's 12 months postpartum with a mildly symptomatic umbilical hernia. She had an uncomplicated pregnancy with spontaneous vaginal delivery, and she states that she believes she's done childbearing. She has no other medical conditions or previous surgery. She doesn't smoke. She drinks 1 to 2 glasses of wine per night. Her body mass index is 31. You do your exam and you appreciate about a 0.5 centimeter hernia with incarcerated fat that you're able to reduce and about a 4 centimeter diastasis recti extending from the umbilicus to the xiphoid region. And here's a representative image of what that looks like on your exam. There's no imaging available.
Thank you. Your evidence has been accepted, or you're accepted into evidence. We'll now hear argument.
Good afternoon, everybody. I first want to say thank you to the AHS for the honor of being able to present here today. So I had a little bit of a hard time presenting or preparing for this talk, trying to think like a lawyer. Generally not, hugely fond of lawyers, so I had
Agreed.
had trouble with this one, but I tried to put together an argument to be on the side of to repair the diastasis in this patient, and I'll show you some reasons why I think that that's the best course in this patient. There's not as much clinical data as our last case, which was awesome, but there actually was a fair amount of literature, actually a lot. And I pulled together a few things just to show you, and hopefully I can convince you that, and the jury, that the right thing to do is to repair the diastasis in this patient. So diastasis, or sorry, my disclosure is not relevant for this talk. So diastasis in not all cases is the same. So very, very variable. We see this in our clinics all the time. Patients coming in, having been told by their primary care that they have a hernia. So, patients like this, thin, muscular, defined, maybe rectus muscles or abdominal wall muscles, with maybe a small or moderate separation between the rectus muscles, whether male or female. We've always all seen this guy come into our clinic, big beer belly. It says when he sits up, he's got a big hump underneath his shirt, and he just noticed it one day, a couple days ago, and it wasn't there. It wasn't there a week ago, which we all know isn't true. Again, told that he had a hernia by his primary care, and then he wants you to fix it because it hurts. And then typical, patients like this who are very typical that we see very commonly, very close to the patient that we're talking about today. So maybe a little bit overweight, male or female, again, with a supraumbilical rectus diastasis in the presence of a hernia, whether it's umbilical or somewhere else within the linea alba. So our patient. So we have a young female, 29 years old. She is done, at least she says she is, with childbearing, postpartum recently in the last year, and has a small hernia, less than 1 centimeter. with a fairly sizable diastasis and symptomatic. So what do we not know? So we know that she has this diastasis. We know she has a hernia. We know that she wants it addressed. We don't know sort of other factors that may play into, you know, what's going on with her and what we should do about it. Mainly things like back pain. General abdominal pain can be associated with diastasis, but more back pain, posture, functional things like ability to do core physical activity, lifting, and those kinds of things. So we don't know about those things based on the description of this case, but those need to be taken into account when we address and take care of patients like this. So what are the options? We'll go through a couple of those. Obviously, those include surgical and conservative management, exercise, you know, physical therapy, those kinds of things, and we'll talk about that in a little bit. So what should we do? Ultimately, my goal is to convince you that we should repair it. So let's just talk a little bit about diastasis, what it is, define it. So we typically define diastasis recti as an inner rectus distance of anything greater than 2 centimeters. It's very common. If you scan through maybe 100 people that have a CAT scan, you know, more than half to 3/4 would have some degree of diastasis recti, whether it's supraumbilical or otherwise. It certainly can occur with without a fascial defect, but very, very commonly occurs with a fascial defect. And very commonly can be mislabeled as a hernia. You know, we have patients all the time coming into clinic saying that they have a hernia. They were told by their primary care physician that they have a hernia. Patients like, you know, the bottom CT scan, who, you know, have very much laxity of the abdominal wall, and their abdominal wall can act like a hernia. So options. So what can we do about these things? Obviously surgical and non-surgical options are available. Lots of cool sort of newer things happening these days in terms of approaches with robotics and laparoscopic approaches. This is a video from Brian Jacob. I appreciate his letting me use his video, but this is a SCOLA. So this is just one option of many to address diastasis and hernia together. But conservative and surgical management are really the two options. Conservative management, I always talk to patients about, you know, when they have diastasis and they come in and you know, surgery is probably not the best option for them. I'd give them basically a card with diastasis recti written on it, and I tell them to go, you know, type it into YouTube or, you know, just search it. And there's, if you do that, there's millions of hits of physical therapists, occupational therapists, personal trainers that have, you know, different workouts and things to address diastasis. Not that many of them work, and we'll look at some data that suggests that really isn't the best option for correcting diastasis, but it is an option. Surgical options, again, there's many. Robotic, laparoscopic, obviously open approaches typically or historically were what was done in terms of plastic surgery addressing these with abdominoplasty and other approaches. There is a lot of literature and many studies that suggest that repairing that, and it's mainly the plastic surgical literature, suggesting an overall quality of life improvement, significant improvement in cosmesis and other functional outcomes related to repair of diastasis. So my argument today to convince the jury and you all is that we should be fixing this patient's diastasis at the time of her hernia repair. And I tried to boil it down to a few sort of ways that I can convince you to do that. And you know, it's hard to find data to either on one side or the other about this, but I found really 3 ways to try to convince you of that. So the first one is taking a look at what happens when we tell a patient to do what I said a minute ago. Go, you know, do some physical therapy, do some workout, try to do some core strengthening, and maybe it'll get better. So this is a study. This is basically a meta-analysis of 16 trials. It's in physiotherapy. This is a physical therapy journal, occupational therapy journal. This is all postpartum females, and within the meta-analysis, all the trials gave the patient some sort of exercise protocol that theoretically or in other literature was suggestive of improvement of diastasis using that. A few trials, mainly 6 trials, showed a very minimal improvement of inner rectus diastasis, approximately 4 millimeters. but generally the rest showed no change whatsoever. So based on the few data studies and things that we have about this, there's really very little that you can do in terms of core strengthening or physical therapy, those kinds of things, to address a diastasis. So if we tell this patient to just go and do some work on her core and we'll fix her hernia and not her diastasis, she's going to end up with continued diastasis. So the next thing, what happens if we just fix the hernia and not the diastasis? What are the outcomes there? This is a study out of Austria. It's a retrospective analysis of 231 consecutive patients who underwent suture-based repair of small hernias, basically very similar to the size of the hernia that the patient has, whether they were primary umbilical or epigastric hernias, all midline defects, and they were basically fixed with suture-based repair and no mesh. And this study basically found an independent risk factor for recurrence of diastasis. So basically 1 in 3 patients who had diastasis at the time of their hernia repair were found to have recurrence at mean follow-up of 31 months. So 1 in 3 patients recurring with hernia-only repair without addressing diastasis, as opposed to 8% with no diastasis associated with the hernia. Again, this is primary repair only. So if we address the hernia without the diastasis, the risk of recurrence is very high. And lastly, this is a very, very applicable study to our patient. This is from a Swedish group, taking a look at 66 postpartum females with symptomatic training-resistant diastasis. So training-resistant meaning attempted physical therapy or some sort of core strengthening activity and did not address their issue. They all underwent repair of their diastasis via suture plication. 75% of them had associated hernia with their diastasis. And this was basically a functional outcomes quality of life study. And at 3 years follow-up, universally with statistical significance, all patients reported significant increases in their aesthetic outcomes, improvement in disability rating index, core physical function tests, and quality of life. And importantly, no reported recurrences of diastasis or hernia at 3 years. So basically, what I've shown you is, number one, diastasis is not going to improve with core strengthening or physical activity, at least not noticeably for the patient, particularly with hernia associated with it. Number two, if we fix the hernia and diastasis is associated with that hernia, it's very, very highly associated with the recurrence of that hernia. And number three, patients, particularly postpartum females, have a significantly increased or improved quality of life and aesthetic outcome associated with fixing their diastasis. So I'll leave it there. I certainly believe that the diastasis should be addressed at the time of this patient's repair, and I'm looking forward to hearing the other side from Gabriel.
Thank you, Counselor. The court will now hear rebuttal.
Hello, hi. I'm Gabriel Arevalo from Houston Methodist. Thank you for the invitation. Okay, we can move to the next slide. These are my conflict of interest. Move to the next slide. Can you hit play? So this is how I felt when I was given this task. Right. But I really didn't want to do it, right? Because there's very little evidence. But then I start thinking, like, I don't placate everybody, because not every patient has a symptom from their diastasis. And there is actually evidence to support that. And same as Keanu Reeves, when in this movie, he goes to the literature and reviews it and comes up with an answer. So we can move. So what do we know from the literature? Thankfully, there's already been a group of experts that have gathered to give us the answer on what to do. These are the European hernia guidelines for rectus diastasis. They were published in 2021. And vast majority of their answers come from 2019 and 2020 from the American Hernia Society, conjoined with them to give us this answer. So the first question is, what do we do if we only have rectus diastasis? Advance. You can placate. But if you have a diastasis and a hernia, what do? You repair the hernia. That's the recommendation. You see, what is the optimal treatment for rectus diastasis with concomitant umbilical hernia? The treatment of choice is a mesh-based repair of a rectus diastasis with concomitant midline hernia. So the treatment is repair the hernia, leave the rectus diastasis alone. Although this recommendation is weak and the level of evidence is low, but where does all this evidence come from? As Pete said, he had a hard time looking for literature, and yes, he's right. There is a hard time looking for literature if you want to placate everybody. So these are studies, like if the two highlighted in yellow are from Cristiano Claus, that he's talking about Escola, and Juarez is talking about REPA. But these are patients with low BMIs less than 25. Our patient has a BMI of 31. So she doesn't qualify, or she's gonna get complications in order to do a Escola of a REPA. Then you look for the two green studies, one of them with 175 patients. What do? They did preperitoneal hernia repairs with mesh overlapping the rectus diastasis. So if you look at it, there is a heterogeneity of techniques. So multiple techniques can be used, but there is no standardized way to address this. And the best thing is to repair the hernia like we know how to repair them best and to prevent recurrence and improve outcomes, and it's a mesh-based repair. So looking at our patient, she has a 29-year-old female with symptomatic umbilical hernia. Look at it, symptomatic. She has no symptoms from her diastasis. She doesn't have back pain, she doesn't have constipation, even if she will have these types of symptoms. The literature is so low to tell you that, oh, I have constipation, placate me, now I'm gonna have normal bowel movements. It's not like that. That's just a conceptual. There is no prospective data to prove that. This lady also has a 4-centimeter rectus diastasis, but there is no imaging. But if you have a hammer, to you, everything will look like a nail. I'll give you an example. Can you play the video, please? So this patient, I asked him to do a Valsalva, and you see a bulging. All right, okay, this looks like diastasis. I asked him to show the next video. I asked him to do a Valsalva and elevate his legs. I do ultrasound, and you look at the distance between the rectus muscles. This is less than 2. So this patient doesn't even have imaging to say, okay, let's go in and placate you. And in this case, for this patient, I did a RTAP to address his umbilical hernia. And we know that fenestrated bipolar from the tip of from their articulating joint to the tip of the instrument, that's 2.2 centimeters. I'm pointing here at the umbilical hernia, but look, he has no rectus diastasis. So our patient doesn't even have imaging to say that she has diastasis, and even it's different to say a rectus diastasis at rest versus rectus diastasis at exertion. If you do Valsalva, elevate your legs, you're bringing the rectus muscle, you're medializing them. So the interrectus diameter diminishes. Another article, and as a matter of fact, this is considered a hidden pearl, a hidden gem. And we're gonna discuss this article tomorrow because it has so much information. And it tells us that interrectus diastasis should be measured in exertion. This lady, we don't even have tests for her or elevating her legs or Valsalva to prove the size of her diastasis. We say it's 4, but maybe it's less. At 4 centimeters, whenever she elevates her legs, maybe we will move her from a D2 to a D1, and she doesn't even complain about it. So the facts to say, hey, she's symptomatic, she has no symptoms. There is no need to say or argue, hey, let's placate her, we will improve her quality of life. When the evidence is low in the literature, treatment should be based on the patient. These should be patient-centered treatments. This patient is concerned about their umbilical hernia, so let's treat her umbilical hernia. And I have a couple of examples here. So the recommendations, I said, they are low, they are not absolute. And the best way to treat this patient is to treat her symptoms, which is the umbilical hernia. She has no functional limitations, and she has not talked about aesthetic concerns. But in a patient with rectus diastasis, the best way to measure her outcome is by asking her quality of life results. So and this comes from the guidelines, from the European hernia guidelines that experts thought about this, and they stated that patient-reported outcomes should measure the best tool to evaluate her clinical symptoms. And her clinical symptoms, again, is the umbilical hernia. So these are examples from my practice. I asked this patient, can you put the audio, please? I asked him specifically, what bothers you?
Here, if I push on something or lean up against something, this doesn't really hurt.
Does that bother you?
It doesn't really hurt.
It doesn't bother him, like the next patient.
Hold it there. Hold it. All right, can you pinpoint where does it bother you?
When the evidence is low, when we don't have literature, the most important thing is patient-centered treatment. Both of these patients are here for the umbilical hernia, and we're gonna treat her umbilical hernia with a mesh-based repair. And if you don't mind, can I bring an expert witness?
I'll allow it.
Okay, here he comes. He might know something. His name is Philip Mason. He was a past president of the European Hernia Society, past president of the Belgian section for abdominal wall, and has written many chapters and many publications about hernia and abdominal wall. So he may give us some information about what to do. So if I ask Dr. Mason, I want to direct your attention to the management of an umbilical hernia in the presence of diastasis. Let's say you have a 31-year-old lady comes to you with an umbilical hernia, but the diastasis itself is causing no symptom or has no symptoms. Do you still placate the diastasis, or you limit your operation to the mesh repair? And this is a video of Professor Philip. We have here the rectus diastasis in this patient, and he is addressing the reason why the patient came looking for help. Close the umbilical hernia, but look, you give a mesh-based repair, but you do a proper mesh-based repair. You overlap the rectus diastasis because you're gonna reinforce this area. The evidence that Pete showed us, the literature that you get hernia recurrence after an umbilical hernia is because these were tissue-based repair, not mesh-based repair.
Jerry, with all due respect to Dr. Moisums, let's not make our decisions based off of videos from Facebook. Thank you.
Well, I got a couple of opinions here from the International Hernia Collaboration. So they asked him, hey, why you didn't stitch the linea alba? Because the patient came here because what was bothering her was her umbilical hernia. I don't know if you're able to see from there. Another guy asked him, hey, I thought that you were going to do it, that you're already there. And he answered, I disagree. It is not because it could be close, it should be close. So this is very important. And I want you to pay attention to this. Just because you can do something doesn't mean you should. Remember, we should do no harm. First, do no harm, like Dr. Scott said. Then nice case demonstration. I thought you will approximate the linea alba. Again, the lady comes in for the treatment of her umbilical hernia. So why is our patient here? Why is our patient consulting? So my case defense is that the literature to placate every single diastasis, there is weak evidence. And when there is weak evidence, we need to focus on patient-centered care. This lady has a symptomatic 0.5 centimeter hernia, not asymptomatic rectus diastasis. Her diastasis may be 4, we don't know because we don't have imaging, which is the best way to diagnose it. And surgery is not just about what we can be done, but what needs to be done for the patient benefit. So first, do no harm. In conclusion, repair the hernia with mesh. Thank you.
Thank you, Counselor. Jurors, you've now heard evidence in the case of rectus diastasis. Please continue deliberating as you've already started without my instruction, and render your verdict when possible. Order in the court, the jury's reached their verdict.
The jury has a question. We are not surgeons, we are not experts, so we would like to know who is Dr. Philip Musom. No, we have a verdict. This was a little bit more difficult because I think there are few things that we learned from these presentations, and I think needs to be addressed in a certain way. So we tend to be more aggressive in this case, and our first reaction is repair the diastasis. The diastasis in female patients was brought up from one of the jury is different from the diastasis in male patients, and the lawyer in favor of the leave it alone only presented male patient cases. The physiology and the anatomy of the diastasis in the female patient is slightly different. We think that it's important to reestablish the physiology of the abdominal wall as much as possible in these patients when we go for a repair. And the only caution advice is, of course, one, you need to be able to do the plication of the linea alba. And there are many different techniques to do so. So you need to be competent and familiar with some of these techniques to be able to offer that repair. You don't want to try anything crazy. And then the second part is the childbearing age. This patient, we know that she's not planning to have more kids. In a different situation, if the patient is planning to have more pregnancies, probably it could be wise also to leave just the hernia repair and the diastasis repair at the second time if the hernia recurs or if she becomes symptomatic.
It is so ordered. Thank you, jurors. We'll now progress to our third case on the docket and our last case, I believe, before happy hour.
All right, thank you, and thanks for everyone for hanging out. This is our last case, and this patient the question is going to be whether we should put in prophylactic mesh or not. I have no financial disclosures, and so this patient is a 61-year-old male with a history of a low anterior section previously for a rectosigmoid adenocarcinoma, and now has a large right intersphincteric mucinous adenocarcinoma. And he has completed his immunotherapy and pelvic radiation. He was restaged with no metastatic disease. And here's his imaging. You can see a very large mass that will require an APR. This is a patient of my colleague, our colorectal surgeon. And the question that we have is, with the APR, this is going to be an end colostomy that this patient will need to live with. And should we put mesh in now as a prophylactic measure, or should we not? And I will allow you guys to fight it out.
Thank you. Those facts have been accepted into evidence. The court will now hear argument.
Good afternoon, everybody. My name is Wendy, and I will take the next 5 minutes to convince you why we need to put prophylactic mesh for this placement of the permanent end colostomy. These are patients who thought they were on their way to recovery after a cancer operation, but little did they know of the consequences that followed. Creation of an ostomy alone is a life-altering change. The development of a peristomal hernia can cause severe lifestyle limitations, such as leakage around the ostomy site, causing skin damage, obstructive symptoms, and significant body dysmorphia. What if I told you there was something we can do to prevent this from happening, or perhaps even delay this from happening? So let's go back to the case presented in front of us. Let's start off by reviewing the patient's risk factors. We know that he is obese. We know that they have received neoadjuvant chemotherapy, and he has underwent a previous umbilical hernia. So what do these things mean as it relates to hernia disease? Let's first talk about obesity. This one's a no-brainer. Everyone understands that weight is directly correlated to the risk of recurrence. The incidence of incisional hernias increases even higher, up to 26 to 39% in patients who have morbid obesity. What about chemotherapy? Would this have an effect on the patient's hernia risks? This is a study from MD Anderson who looked at chemotherapy, closure techniques, and its effect on postoperative ventral incisional hernia repairs in patients who have colon cancer. We know that the rate of incisional hernia formation at 5 years was 55%. This is higher for the group who received adjuvant chemotherapy than those who did not. Now, further analysis demonstrated that neoadjuvant chemotherapy specifically had an independent association with high rates of incisional hernia. Lastly, the patient had a previous umbilical hernia. This perhaps reveals an inherent collagen weakness. What about the quality of collagen in oncologic patients? This is a study out of Romania that showed that oncologic patients have more abundant, weaker type 3 collagen, increasing their risk of development of a hernia recurrence. So I've essentially spent the last couple of minutes just talking about the patient's risk factors, and this would essentially make him a high-risk patient. Now let's turn our focus and specifically focus on peristomal hernias. Peristomal hernias are the most common complication after creation of an end colostomy, with the incidence up to 50%, and the risk continues lifelong. Some may even consider the development of a peristomal hernia to be inevitable. It's just a matter of time. Given the high risk development of a peristomal hernia, the suboptimal outcomes of repair, there is a justifiable demand to look for a more effective preventative approach. Now, this is the Dutch PREVENT trial in 2017 that looked at placement of prophylactic mesh during end colostomy formation. They had a total of 150 patients that they recruited, and after exclusion, 133 patients were divided into 2 groups. One was the prophylactic mesh, and the other was the non-mesh group. In the mesh group, they placed a 10 by 15 centimeter polypropylene mesh in the retromuscular position in a keyhole fashion. Outcomes were studied at 3 weeks, 3 months, and 1 year. Only 4.5% of the mesh group developed a peristomal hernia versus 24.2% in the non-mesh group after 1 year. Quality of life overall was poor for patients who develop a peristomal hernia, however, was not statistically significant between the 2 groups. Costs may be higher in the immediate operative period due to the use of mesh and longer operative times. However, there was no significant difference in cost after 1 year. 2 years ago, this group presented us with their follow-up 5-year data. They had 113 patients that they analyzed for the trial due to the loss of follow-up. 27.8% of patients developed a peristomal hernia in the mesh group versus 37.2% in the non-mesh group. Now, this unfortunately did not show any statistical significance. However, I want to point out, this is a 10% difference with a really small N value. The 5-year follow-up demonstrated that it was also more cost-effective in this mesh group despite the early immediate perioperative expense. The overall quality of life showed no differences between the 2 groups. Now, the overall conclusion from this study deemed that the placement of prophylactic mesh perhaps may not prevent peristomal hernias, but it may delay the onset of disease without having any morbidity. This is another study that was published last year from Finland and Sweden using a different mesh technique. So they talked about the use of a funnel mesh, and this is what the mesh itself looks like. They had a total of 143 patients that were randomized, and the result demonstrated a 10% incidence in the mesh group versus 37% incidence of peristomal hernias in the non-mesh group, demonstrating very significant statistical significance. There has been other studies that have been published regarding the use of prophylactic mesh in prevention of peristomal hernias. Therefore, the European Hernia Society actually published a guideline after systematic review. Now, there are 12 randomized control studies that were looked at, with 3 looking at long-term data. A total of over 1,000 patients were analyzed. There was a significant reduction of peristomal hernias in the prophylactic mesh group versus the non-mesh group. And this was significant not just for the short term, but also for the long-term 5-year follow-up. There's also a less risk of needing surgery for peristomal hernia in the mesh group, 2% versus 5% in the non-mesh group, which means that even with recurrent occurrence, the need for surgery for this peristomal hernia is less. There is no difference in factor of quality of life or perioperative morbidity. Now, this is something that Dr. Chen spoke about earlier yesterday in the morning. It was a quote from Dr. Neil Smart. Peristomal hernias are not meant to be fixed in perpetuity. The importance is in the quality of life. So the overall consensus from the European Hernia Society states that prophylactic mesh placement for end colostomy is associated with a reduced risk of peristomal hernias. They placed a strong recommendation for the use in high-risk populations and a considerable recommendation for use in all other populations. So perhaps for this patient who has obesity, who has had neoadjuvant therapy, and also a previous umbilical hernia, may deserve some mesh to prevent these awful peristomal hernias from occurring. I leave you with one simple slogan: prevent peristomal hernias, place prophylactic mesh. Thank you.
Thank you, Counselor. The court will now hear rebuttal argument.
All right. Thank you, everybody, for having me. I'm Kayla Blake from the University of Tennessee. Thank you. It's an honor to be here. Thank you, Your Honor. And I'm about to convince you all why you should not place prophylactic mesh in this patient. So let's get into it. I have no disclosures that are relevant. So let's talk about this paper that Dr. Liu already brought up. Thank you for briefing the audience on this. Let's get into it and let's talk about it and let's figure out exactly why she's wrong. So the EHS did this whole meta-analysis for us right here in this moment to talk about this patient population. So the EHS did a great meta-analysis. They looked specifically at prophylactic mesh placed for patients getting a peristomal hernia for an end colostomy. So all these patients got an end colostomy just like our patient today. And they found 12 randomized controlled trials that talked about this. So let's go through it. They did, at the end of the day, find that there is a reduced risk of developing a peristomal hernia when you place prophylactic mesh. The odds ratio is 0.33. However, let's dive into this. The heterogeneity between these studies was 74%. That is extremely high. What does that mean? That means that this result in lowering your hernia rate is variable depending on what study you look at. So you can see that half of these studies, the confidence interval is crossing 1. The other half of the studies, the confidence interval is a huge range. So they have a message in there, if you read the text, that there is a variability in what you're looking at. And that variability is either from the patient population's different, the method that we're using the mesh is different, what you're doing in the operation room's different, the contamination levels are different. So unless your patient is that specific patient population that is this study, that does not necessarily apply. So take this with a slight grain of salt, because out of 12 randomized controlled trials, half of them did not show a difference. I appreciate this study too, because they did go down further and they broke up the patients, and they broke these patients up into low, moderate, and high risk patients to develop that hernia. So our patient today has obesity. They're probably more on the moderate to higher risk chance of getting a hernia. Yes. But so let's dive into this. So when you look at that column to the right, the patients who got prophylactic mesh, those numbers are lower. They did have a lower overall risk of developing a peristomal hernia, but they still, a large chunk of them developed a hernia. So even if you put mesh in these patients, 16 to 29% of patients that you're going in and putting mesh after this APR are going to get a hernia. That's a number. That's a real number to talk about. And there was a more recent meta-analysis that was published this year that included the majority of those studies that were quoted in that EHS paper. And they found that the retromuscular plane is the most effective plane to use if you are going to place it at a time of end colostomy to prevent a peristomal hernia. So let's talk about that. So for our patient today, he's here for a rectal cancer. So if we go in and put a retromuscular mesh, are we just putting the mesh around the ostomy? Are we putting it along the midline incision too? It kind of doesn't make sense not to also cover that midline incision. So then we're talking about a Reeve stopa. Okay, when your posterior rectus sheaths don't reach, Are we giving this patient a TAR? Are we about to TAR these patients that are in here for a rectal cancer? Like, that does not make sense to me. And not that billing and getting reimbursed is everything in our world, but there is not reimbursement for this procedure. So if we're going in and potentially putting a big retromuscular mesh in a patient that could become a TAR, you're not getting paid for that work. It's 7 p.m., the colorectal surgeons are done, and it's you asking yourself, why am I doing this at the end of the day? Right now, we have a CPT code for this that's a temporary code just used to track data for this, but there's no set reimbursement rate to place prophylactic mesh. And so it's just between you and your insurance company and if they think that was indicated or not. So you're probably not going to get paid, long story short. Not that that's everything, but it's something. So going back to that group of 16 to 29% of patients, you put in mesh, you potentially put in retromuscular mesh, and those patients are going to come back to you. So what's your next step after that? What's your next move? So you've already used that plane, you've already committed them to this route. I think what's an even stronger argument is let's look at the patients who did not get prophylactic mesh. Let's look at those patients. If you are a lower risk patient and you get a permanent end colostomy, the chances that you're going to get a hernia is less than the chances of you going to get a hernia. The majority of patients who you just bring up an end colostomy are not going to get a peristomal hernia. So in a low-risk patient, 2/3 of patients are not going to get a hernia. So why are we spending all this time talking about potentially putting in a retromuscular mesh, potentially committing someone to a TAR who's not even going to get a hernia? Again, our patient is on the obese side, so you can say they're on that moderate to high level. So it is becoming more of a 50-50 shot on if they get a hernia. But if it's 7 p.m., there's a big tough rectal case, there's stool spillage, and I have a 50-50 shot on if this patient is going to get a hernia or not, am I going to commit myself to a big open retromuscular repair? No, I'm not. Even more of an argument is that this data found that there is no difference in the patient's quality of life. Isn't the goal of all of this, putting in mesh, preventing a hernia, to improve our patient's quality of life? Isn't that the goal of what we do? That is the goal, and there's no difference. So when you look at both of these groups, if you put in mesh or you didn't put in mesh at the time of their end colostomy, their life is the same either way. And when you look at the heterogeneity between these studies, there's zero heterogeneity. That is a non-variable result right there. Let's go even further. The patients who required surgery for a peristomal hernia, that confidence interval crosses 1. There is no difference. There's a trend towards less surgery, but there's no difference statistically. And there's low heterogeneity in that as well. So to wrap it up, place at a mean follow-up of 5 years, which was that EHS study, the majority of patients who do not get mesh also do not get a hernia. So why are we doing this? There's no difference in the patient's quality of life. There's no difference in surgery for peristomal hernia at 5 years. If you do put mesh in, 16 to 29% of those patients are going to come back, and you've already used the retromuscular plane and you didn't get paid for it. Thank you.
Thank you, Counselor. Jury, you may deliberate. In the case of prophylactic mesh, the jury has reached their verdict.
Well, the jury has debated again a lot about this, and we came to the conclusion that the indication for the mesh is not as strong as for the arguments in favor of not placing the mesh. We considered in our decision also the risk factors that this patient has. Of course, that is something that can needs to be taken into consideration. We really think that it's paramount to do the right stoma in the first place. So we were stressing about the technique of building the stoma that is not in the semilunar line. It needs to be done with the all right technique. That will reduce the short-term occurrence of parastomal hernia. In the long term, we don't see a strong argument for routinely place the mesh at this point.
It is so ordered, and thus concludes this court's term, and we hope to resume next year at the next AHS meeting. Thank you.